Welcome, and thank you for joining this week's webinar in the COVID-19 and Humanitarian Settings Knowledge and Experience Sharing webinar series. We will begin shortly. During this webinar, participant microphones have been muted. However, we do encourage you to make use of the chat box to communicate with the presenters and ask any questions. Access to today's recording will be available after the webinar at readyinitiative.org and on the Johns Hopkins Center for Communication Programs YouTube page. Before we begin, I would also like to highlight an upcoming event, the annual MSF Scientific Days International, this year taking place entirely online on May 13th and 14th. This event is intended for the medical humanitarian community to come together to share the very best medical research and innovation taking place across MSF and other organizations. This year, both keynote sessions will address the COVID-19 outbreak. For more information and to sign up to attend, please visit the MSF UK website at msf.org.uk. It is now my pleasure to introduce our moderator for today, from the University of California, Berkeley School of Public Health, Dr. Rohini Haar. Welcome, Dr. Haar.
I am excited to moderate today. The focus of today's webinar is going to be on case management around COVID-19. Especially in humanitarian settings. So I will keep it very brief, but I wanted to introduce our speakers. We're going to have Dr. Bhargavi Rao speaking first, and she'll speak for about 15 minutes or so. She is the clinical focal point for COVID-19 response at MSF at the Operational Center in Amsterdam, but you're based in London. And she's worked on infectious disease programming across various contexts, and is trained as a medical doctor with a PhD in infectious disease epidemiology. Next, we'll have Rachel Cummings from Save the Children. She's been there for over 10 years and is currently the director of the Humanitarian Public Health at Save the Children. She's a nurse by training with an MSc in public health. And our second discussant was to be Dr. Mukhtar Abdullah from Al-Shab Hospital in Khartoum in Sudan, who was, I think, a critical care physician there. We're having some trouble reaching him. So if he's able to join us, that would be great. If not, we might move straight to question and answer. So while the speakers are giving their presentations, please feel free to enter questions in the chat, and we will hopefully have a really rich discussion at the end on case management. So I'll just start with posing. I have so many questions already, but really, I work in an emergency room here in Oakland, California, where the COVID case management is already complicated. And so I've, comparing that to the humanitarian sector, I would love to hear from you the challenges and how you really manage these cases without testing, something we're dealing with in the United States and the UK. And, you know, if you have surveillance and operational definitions, and what lessons you have for other humanitarian and low resource settings, or even high resource settings, given that everything is obviously very context specific, but that there could be some crossover of learning. Without ado, Dr. Rao, do you want to go ahead and get started?
Hi, so good morning, good afternoon, friends. I want to set expectations from the very start for this talk. I have no doubt that there are many, many more respected and knowledgeable clinicians than I online today. And I'm also just going to assume that nobody wants a lecture on novel therapies or details of the minutiae of testing with lots of bullet points and references. So I've sort of taken as my inspiration a paper within MSF at the moment, so written by Sean Healy, who is head of our analysis unit, and it's called The Storm and the Flood. And it's essentially setting the context that we are now globally in amidst the storm waves of this COVID-19 pandemic, with many countries' health systems really struggling with the flood of critically ill patients, and importantly, with the prospect of many more to come. So I'd like to thank the organisers right at the start for this opportunity to share with you some of the challenges that are shaping the way that MSF is currently approaching case management of this flood of COVID-19 cases, for now at least, given the ever-changing sort of storm conditions. Next slide, please, Ryan. So this is a bit like a malaria lecture where it's an unspoken rule that the first slide must always be the parasite life cycle. So apologies for including a picture of this virus that has turned our lives upside down. There are so many aspects of this pandemic that are challenging to us as a medical humanitarian community. But I think I'd like to highlight just a few things that are particularly relevant to developing a case management response. I think firstly, we know that this virus spreads very rapidly and importantly pre-symptomatically. So work from China and some of the other countries might suggest that about 80% of those who are infected won't need hospital level care. But even assuming this is similar for our context, if transmission gets going, then those remaining 20% of cases who need hospitalization is more than enough to collapse the hospital system of any low or middle income country. And so we really need to be thinking about case management outside inpatient facilities, but also how to organize appropriate home management and follow-up for this highly infectious disease with a long period of potential infectiousness and a long period of being symptomatic, often with a late deterioration. So really important clinical features. I think the other second thing sort of really as a challenge within this, and I'm not telling you anything you don't know here, is that there is no vaccine or proven treatment as yet, and nor is there likely to be soon in any way that is feasible to be implemented across our settings. So our main response strategies have to be non-pharmaceutical interventions. And I think it's important to be really clear, we are not going to case manage our way out of this pandemic. And importantly, as we've already sort of slightly spoken about, there is very limited access to reliable testing in the US and the UK, let alone most of our settings. So the likelihood is really that we won't know whether the patient in front of us is a case at all, only suspected to be, and that has all the implications in itself for management, quarantine and isolation in contexts where people are often displaced or there are authoritarian regimes, all sorts of things. So some real implications around that. And then I think thirdly, all countries are already facing significant resource constraints in responding to COVID-19, especially in terms of PPE, personal protective equipment, but also importantly in terms of human resources. Clinical staff, as we know from our ongoing responses in the UK and the US, who are at high risk of infection. And so we really have to mitigate, really have to factor in mitigating the risks of significant staff illness into our case management strategies. Next slide, please, Ryan. So I think the first point here is there is so much we don't know. Despite the truly extraordinary progress that has been made in understanding this new virus and all the experience of global health actors that we've accrued in responding to epidemics, we ourselves are having to rapidly come to terms with the fact that this is not cholera, this is not measles, this isn't even Ebola. And it's a novel virus that we are only at the beginning of a very long journey towards understanding. And also, despite all the goodwill of sharing information, and perhaps in spite of all the sharing of non-peer-reviewed science by social media, we are continually updating what we know about this virus, how it interacts with our biology, our society, within our homes, and especially with clinical relevance to humanitarian settings, what this disease looks like in contexts when so few of the population are over the age of 60, or who are known to have the diagnoses of the same risk factors that were seen in Italy or France, but have very different comorbidities. And I think it's this lack of information. We are already getting feedback from field colleagues about how uncomfortable this uncertainty makes them feel. The difficulty of having to give answers, of not being able to give answers or saying, I don't know, when asked by the Ministry of Health officials, feeling as though they've lost face when they have to reverse advice that they gave just a week ago. We are going to have to get comfortable very fast with being uncomfortable, basically. For effective case management and program development, we need to anticipate how the virus interacts with diseases such as TB, HIV, measles, malnutrition. Although children here in the West have had mainly mild disease. We don't know if children with recent measles infections or sickle cell will be more at risk of severe disease. And how do we prepare our pediatric programs for that? Can latent or old TB potentiate deterioration? But I think let's even just start at the beginning. Given our lack of testing capacity at the moment, we are all using the WHO case definition for suspect cases. But in a setting where malaria is endemic, or TB, HIV, Kala-Azar commonplace, and where even general laboratory testing and radiology is limited, and having a CRP is a dream in most of my projects, how do we rapidly differentiate the presentation of a COVID case from diseases that both can co-infect the same patient, but also have significant symptom overlap with coronavirus? So that's TB, HIV, malaria, Kala-Azar. And then what are the implications for that on how we isolate and how we cohort suspected cases? So what are the implications of putting a TB patient in the same ward with as suspect COVID cases? Because I assume that many of us are going to be doing what we're having to do, which is cohort these patients together within our hospitals. Isolation beds, single rooms are a dream. So it's really critical that as part of case management for us, we have to include an assessment as much as possible of the prevailing infectious diseases threats, be it malaria, TB, HIV status, whether stable or unstable, as well as sort of an assessment of diabetes and all the other risk factors already identified. Next slide, please, Ryan. But our lack of understanding of how cases may present in such settings and our lack of testing capacity also really affects our understanding of where this virus is. And integral to this WHO case definition is contact with a case, a contact with a known case, or travel to an area of ongoing transmission. But we already know that surveillance systems in our settings can be very weak, that knowledge sharing is poor, and the knock-on effect of that is yet more uncertainty and yet more inability really to make information-driven decisions, especially when this photo shows essentially where the most common site that people attend for a fever or a cough, an ICCM site, or a community malaria point, or a basic health post staffed by a community healthcare worker. Case management here means making decisions in a situation of huge uncertainty, but we can't wait for perfect information before making our protocols. So we have to think really carefully about how we incorporate considerations of COVID into those really simple algorithms for community healthcare workers at this level, both keeping them safe and reducing community transmission, given that we already know that family structures in these communities are often large and multi-generational. We also know that certainly, what we know from here in the West is that children often have very non-specific symptoms. So how do I train a community healthcare worker to assess the risk of a child with malnutrition or recent measles who now has dyspnea? What do I say to a young mother with a positive RDT and fever? Like, how do I refer her when I know that how do I compute the value of that positive malaria RDT? And then added to that complication, how do I do any of this when PPE is in short supply? And I know that the webinar last week was on prioritization, programmatic prioritization. And I would really like to reiterate that for me, it is vital that we keep those programs going that genuinely save lives, such as bed net distribution, immunizations, treatment for malaria, pneumonia, diarrhea. We have to keep them going. I found out today that 24 countries, including several with large measles outbreaks, are now delaying vaccination. The long-term consequences of that are going to be huge. So whatever we don't know about this disease, what we do know is that children with symptoms of COVID are much more likely not to have it or to be seriously, or actually be seriously affected by it, are much more likely to have one of these three diseases that cause the most childhood mortality and are genuinely treatable. We have to continue to provide these services, and our main consideration or obligation should be how to keep our community healthcare workers, colleagues, protected and safe, rather than closing programs, or as I've been hearing from several countries, even just discouraging care seeking. Next slide, please, Ryan. I'm going to do a really quick aside here for a word on fever. Appallingly, we have heard that some manufacturers of the vast majority of malaria RDTs are thinking of switching wholesale away from the production of malaria tests to entirely COVID testing. We, along with the International RDT Task Force, have written to the manufacturers involved. There will hopefully be letters in medical journals, and this has already been picked up by some major media outlets. The Guardian did a sort of a mention of this in one of the stories last week. But given that companies can get about 18 cents for a rapid malaria diagnostic test and $10 for a COVID test, I think we have to come to terms with the fact that malaria tests are going to be deprioritized, and our reliance on point of care testing as a diagnosis for malaria is going to be challenged. So in essence, unless this decision by the companies is reversed, this is likely to mean a pivot to presumptive treatment of fever with anti-malarials in malaria endemic countries. And this is all happening just as malaria season is starting to rise. This has a scary potential for increasing anti-malarial resistance, especially given that we're essentially really just reliant on one class of drugs as a treatment option in artemisinin and combination therapies. And since fever is likely to be the most common presenting complaint for coronavirus, without the ability to diagnose malaria, this just really adds to the sort of fog of our current case management challenge. Next slide, please, Ryan. So added to this, and I'm really sorry for the bleakness of this presentation, but I think there is also very little we can do, and we have to be honest with ourselves about this. We already know that there is no curative treatment at present. Novel, off-label, experimental treatments, whatever you want to call them, might or might not sort of delay progression, shorten sick days, or even reduce the risk of mortality. But the mainstay of management is still supportive critical care. And in the UK, the mortality rate for patients once they need ventilation is over 50%. So that's with full ventilatory and circulatory response to support, So I've got to be honest with you, I can count on my fingers and toes the number of our missions that can care for a critical intubated patient. We can't manage vasopressors or central lines, really. Cardiac monitoring for QT prolongation is just not possible in most of our settings. Our reality for these critically sick patients is going to be much more along the lines of stringent triage and severity assessment at health facilities, admitting only those in that severe or critical category, so those not maintaining SATs of more than 93% on room air, only admitting those if they are assessed as likely to benefit from the therapies we can offer. And those are really just oxygen, low flow or vial concentrators, treatment of co-infections, fluids, awake prone positioning, mental health support, and then minimizing where possible complications may occur. So thromboembolic disease, despite this global shortage of low molecular weight heparin. Next slide, please. And I think the other thing that is really important is that if the modelling is correct, and we thank our colleagues at Imperial College, at the London School, Johns Hopkins, all the others, if the modelling is correct, then many health systems and many healthcare providers are going to be overwhelmed at some point by patients. This is going to push us to make some really difficult and even tragic choices as resources become constrained increasingly. So what happens when ventilation is impossible? How do we decide when to withdraw treatment if oxygen is limited? Triage, for those of us who've worked often in the field, is a concept really well known to us. Principles for situations of extremity where not everyone can be treated. Principles on who should receive treatment and who should not. But I think the moral difficulties of making these choices should not be underestimated. We're switching from our usual logic centered on the interests of the individual patient as clinicians to a much more utilitarian approach which prioritizes that collective interest. And we will be doing this at volume. So in order to avert some of the moral distress from our colleagues in the field, we have to provide clear advance guidance on when to institute end-of-life care and give them really strong ethical frameworks for field level decision-making on how to classify or prioritize or deprioritize individual patients for care. And importantly, we need to prepare our teams with culturally appropriate messages to communicate for patients, for their families, and to the communities at large, because home-based palliative care will also become a necessity. Next slide, please, Ryan. So community is key. It's really ubiquitous to make this statement. It's like one of those other sort of, necessities of any NGO kind of doing a presentation at the moment. And I think it's fair to say community engagement has not been a strong point of many humanitarian actors, but many of our organizations have learned significant lessons in the aftermath of Ebola in West Africa and recently in the DRC. And to me, it's very evident that the context of COVID in low and middle income countries, the community is key because we will never have enough hospital beds. And this will go on for months and years in the absence of a more feasible therapeutic or vaccine. So as I said before, we are not going to treat our way out of this pandemic. So the community is key, whether from the perspective of self-protection, and I know Francesco Cecchi spoke about this in the first webinar, but also from the case management perspective. We know transmission can be pre-symptomatic. We know that this disease has a long incubation period, and we know that symptoms are often prolonged beyond any realistic bed capacity, despite being very minor initially. And so this means that case management has to run along the lines of early diagnosis as much as possible, push that to the community. Isolation in early stages of an outbreak, contact tracing, if at all possible, again, that has to be at the community. Home management for those who are mild or moderate in terms of risk categories, so not hypoxic on room air. Management of co-infections, simple ones such as malaria, and then importantly, community-based follow-up for discharge. So for discharge, but also to check on deterioration, especially since, and this is uncertainty again, we don't know what the course of disease looks like in our populations, but we know from the ongoing situations it can be delayed and very rapid when it does occur. Next slide, please, Ryan. And I think this is new for us. It certainly is new for us at MSF. How do we manage patients at home and follow them up? Are telephone consultations feasible? Here in the UK, GPs are trained for assessing patients on the telephone. But do we have the right HR or the right tech to actually do this? Can we train community healthcare workers to assess COVID severity from outside the door? What dyspnea scales are appropriate? Can we monitor SATs in the community? I have lots of questions and no answers to this, but we can't wait. This is how we must plan and again, become comfortable with being uncomfortable. And a really short kind of aside here on off-label therapies, because I'm sure there will be questions on those. We have considered the options that are feasible in our context and actually really available, which at present really is chloroquine, hydroxychloroquine, and Kaletra to some degree. And given the risk-benefit ratio, which from our understanding has swung towards risk, if not appropriately monitored, our position is really going to be to use them in very controlled or in trial circumstances, needing approval at the highest medical director level. They are not at the core of our case management strategy at the moment, but that may change. Next slide, please, Ryan. And just a quick note, I'm not an IPC expert, but we always have to consider how our case management strategies impacts healthcare workers and our duty of care to them. Remember that there are lots of infections of healthcare workers in the green zone rather than in the red. In the red, we do PPE, that's fine. But our case definitions are not necessarily good enough to make sure that our healthcare workers are kept safe in the green zone. And that has implications for ANC, that has implications for all of the other ongoing services that need to be going. So just remember that green zones cause infections too. And importantly, we need to offer our staff some mental health support. So next slide, please. This is my final slide, which is an impossible to read algorithm, which is as it should be, I think. And I just wanted to say that we are very happy to share these. Please do let us know if we can sort of share the guidelines that we've written. There are lots of provisos about context and what is possible. And we are updating these weekly. And so I would also say that every guideline is time limited at the moment. But essentially it revolves around early recognition of cases, specifically oxygen saturations when patients are even still looking well. Because if you're a community healthcare worker, it's hard to know kind of what ill and not ill looks like at this level, with this degree of nuance. Treat coexisting illnesses and co-infections. Protect your healthcare workers and manage at home as much as possible. Please be in contact. My thanks to all my intersectional colleagues at MSF and Sean Healy, who really has provided a lot of the thinking for this.
Thank you, Dr. Rao. Before we head to Ms. Cummings, let me just remind you, if you have any questions, I see a lot coming up in the chat room, but please add your questions there. And Dr. Momin, who's from Sudan, has been able to join us, so he'll go after Ms. Cummings. Go ahead.
Fantastic, thank you. Thanks very much, Dr. Haar and Dr. Rao. I won't take long because obviously we have another speaker now, which is fantastic. But It's been in a way quite reassuring, Dr. Rao, to listen to your presentation. And I think my takeaway is we're not going to case manage our way out of this. And that to me resonates very strongly with the conversations that we've been having at Save the Children and obviously with our teams on the country office level. I think Save the Children have been part of the conversations quite recently in Cox's Bazar, and I think Cox's Bazar is a good example, sort of a microcosm of all the challenges that you've listed out in your presentation. We know that there are not going to be enough hospital beds for isolation and treatment centres, even though there's 5 or 6 partners building those within Cox's Bazar. And we know that the continuation of essential services, as you mentioned, is absolutely critical, learning from West Africa and the impact that the Ebola outbreak had on maternal mortality, for example. We need to ensure that we're able to continue the delivery of those essential services whilst maintaining safety for our staff and safety for the patients arriving in those essential services. And I think, you know, the global challenges of personal protective equipment and accessing PPE in the UK, in the US, and globally, it's extraordinary how we have not got this right at all, and it's a very critical organisational and sector-wide concern, I think, in terms of how do we ensure the safety of our staff, as you mentioned, and then, you know, the challenge acknowledging that we will not have enough case management beds in a facility. How do we then support community members and household members to provide care in those difficult contexts in those households? And the main sort of connection between us is that community health worker, and being very cognizant that we often overburden community health workers and have very high expectations of community health workers when often they have a very small amount of training, their pay is very small. So I think we have to be really mindful of that. And then, of course, acknowledging that, you know, maybe 30% of staff will also be off sick at some point. So we haven't got a massive groundswell of community health workers and health volunteers. I think one of the critical points that you mentioned also is this community engagement, or talking to and listening to communities, which, as you said, NGOs are not necessarily historically very good at that. And I think we're definitely trying, certainly as Save the Children across the sector, I see real endeavour to listen to communities, ensure community members have information. How do they understand COVID? How is that contextualised? And also, how do they then make decisions, mainly at a household level, in terms of protecting their most vulnerable? And obviously, Francesco and others have done the work on shielding, but also taking that right down to a household level. How do you protect your most vulnerable? Which is exactly the same conversations we're having in the UK and the US in terms of elderly and comorbidities. So I think the other thing that I'd really be interested to talk to you more about, and I think there's probably a lot of people on the call, in terms of the ethical conversations and ethical framework for decision making. And that's something that Save the Children sort of grappling with now. But I think it would be great if we could have that sort of wider conversation in terms of ethical considerations for individual clinical staff, trying to remove that moral distress that we've all experienced in previous outbreaks and previous work. And I think that would be a great opportunity for us to share learning and share some of that critical thinking. Thank you.
Great, thank you. And I wanted to quickly introduce Dr. Mukhtar Abdullah. He's a consultant pulmonologist at Al-Shab Hospital in Khartoum and head of the Sudanese Chest Physician Association. And he's managing the COVID-19 pandemic at the Federal Ministry of Health in Sudan. Thanks for joining us. Dr. Momin, I'm glad you were able to. Do you want to give us a few minutes?
Thank you very much for the invitation. I hope the voice is clear. Is it clear?
Yeah,
okay.
We can hear you.
Yeah, thank you. You know, we started to have cases for COVID-19 since 12th of March. This is the first reported case. It was on 12th of March. So since that time until yesterday, we reported 700 almost 800 cases, and we have 45 deaths, and we have 70 cured patients. We have almost 10 facilities for isolation for COVID-19 patients in Khartoum state. And in Sudan, as you know, we have 18 states. Each state is asked to prepare an isolation facility, and they did. The bulk of the patients in Khartoum, most of this, about 800 cases, most of them in Khartoum. Scanty or sporadic cases in each state, and so on. As I said, in Khartoum, we have almost 10 facilities for isolation. We didn't use them all yet. Just now, maybe we are using about 4 isolation facilities till now. The isolation facilities, we have maybe in Khartoum around 100 ICU beds ready for the patients. What is used till now? Maybe tens of these beds till now. And we used to give our patients azithromycin for the symptomatic patients. Azithromycin, ceftriaxone, and hydroxychloroquine, plus paracetamol, vitamin C, and so on. Really, we have a marvelous response regarding the usage of hydroxychloroquine in Sudan.
Sorry, Dr. Momin, I can't hear you. Do you want to? I think you're muted. Go ahead.
Okay, thank you. So as I said, we have a marvelous response for the hydroxychloroquine in Sudan. Since the first patient that we used it for him, and you know, we have 1 year back we had a marvelous revolution in Sudan. And for the last 30 years, maybe the health sector was not doing well in Sudan. We acquired very ineffective hospitals. And we try to manage all things now, treating COVID, treating non-COVID patients, working in our units in hospitals, working with the Ministry of Health in making the protocols and the guidelines for the COVID-19 in Sudan. And I think we need, if we ask what we need, probably we need a lot of help, because still we don't know what is going to occur in the coming days. We started with 1 case, 2, 3, then 10 every day. Last day we reported 100 cases yesterday, and we don't know what is going to be in the coming days. So I think Sudan needs an urgent support, to prevent the health system from collapse. Yeah, we have shortage in doctors. We have shortage in nurses. We used to work maybe 20 hours per day to cover the shortage. We have very limited resources. We have very limited PPEs for our staff. And I think we need an urgent help. And if you have any question, and yeah.
Okay, great. Thank you. So I see a ton of questions coming in, so maybe we can just start with a few of those. Dr. Rao, when you started speaking about the ethical decision-making and rationing, a lot of questions came in about that, both in terms of how you engage with community leaders in prioritization of intensive care, in adhering to like local beliefs and culture, and also kind of what's the threshold for making decisions on palliative care, especially when in the absence of ventilators or other equipment. And also I think in terms of managing, so let me stop there and say if you or if anyone else has thoughts on kind of the ethical decision-making and rationing and how you're doing that in the field, or what kind of guidance you're giving to your field teams, that might be really useful to hear about.
Thanks to everyone for all these incredible questions. I will start by saying that exactly that ethical debate is actually the focus of our keynote discussion at the scientific days. So, you know, and so if anyone is interested, then please do tune in, because it will be with people who understand a lot more about the ethics than I do. But I think that there are two things there. One is about sort of helping with the moral distress for our colleagues, and in a sense taking on some of that burden ourselves, because we are able to because when you're making those decisions at volume in that sort of almost mass casualty scenario, except that this isn't going to be, then you do need assistance, and you need guidance, and you don't need sometimes that decision to be on your shoulders. And I think that these will depend very much on the sorts of cases we're seeing. So we have given our field guidelines around kind of, given that we can't ventilate or intubate, I mean, essentially any patient who requires that level of care will need to be actively managed in terms of end-of-life care. So I think it's important to think of palliative care not as some sort of abandoning of a patient, but that this is an active form of care in itself. But I think we have to be realistic that in many of our settings, we cannot intubate a patient. We cannot put central lines in and give them vasopressors. And so in a sense, it's how long do you, if someone is in that state, we cannot do anything. And that is very clear in our guidelines, and we've made it clear that, you know, we are not shipping in hundreds of new kind of ventilators and then putting poorly trained staff in front of them, and, you know, generating lots of aerosols and infecting them as well. I think that would also be a lack of duty of care to our staff. But I think that there is also a sort of importance more generally about kind of ethical questions and how are resources distributed between patients. And I think there are all sorts of things that play in there, be it fairness or equal respect, minimizing the harm caused by a pandemic, maximizing benefits, reciprocity, flexibility, sort of who participates in that sort of decision. There are lots of things, and we've actually produced a very beautifully written piece of community guidance about how to I don't want to use the word engage communities, because I think that has many meanings, and one of the questions has already come up, in fact, from an ex-MSFer, Marc Dubois, on the chat. I was quite clear when I talked about community as key for this. I mean community case management. I am not talking about community engagement, because I think that has something that's very different. The discussion around shielding and home isolation and things like that is a question, or sort of community prevention is a question of community engagement, and I think there does need to be some really rigorous tools drawn up to see how is that assessed. How do you communicate risks of a disease that we're not yet seeing quite the impact of at that time? How do you explain shielding to high risk communities that, you know, it may be a year or 18 months that they need to be in a specific green zone? So I think from that perspective, you're right. You know, how do we engage these communities is going to be key, and we need to think about that very carefully. We've tried to develop some sort of approaches at MSF that I'm sure my social sciences colleagues will be very happy to share. From a clinical perspective, though, we also need to think about how we manage at home in the community, and that's a case management. That's a clinical decision.
There's also quite a few questions about how you manage initially in the cases in terms of, is there, for instance, one person asked, can syndromic approach be used in lower and middle income countries, especially given the lack of testing, but then complicated by the fact that the syndrome for COVID is fever, shortness of breath, and URI symptoms, really. And so, you know, how do you manage that very, like, specifically? What guidance do you give? And then I think a bunch of people also asked, how do you translate that to how you separate people between isolation centers or hospitals or other facilities versus at home? And do you give your guidance to your organizations on that?
I absolutely agree. That is the very crux of the matter. I mean, when you're saying, should we go towards syndromic management, that's exactly what we're doing. We do not anticipate having routine testing in any of our sites. This has to be done on the basis of the WHO case definition, for us, at least at the moment. So the basic screening questions and assessment of symptoms, recognizing that some of the patients that you send to a non-COVID sort of pathway may well likely have COVID. Actually, you know, children with diarrhea, we know 50% of, that's 50% of their case presentation. So, you know, even if you get down the stream of being thought of as a possible suspect COVID case, as you know, the management, even if you test positive for malaria, that doesn't mean that you don't have COVID, of course. So I think that it has to be, that is the inherent problem of what we are going to be facing. And how do you, on the basis of just a suspect case definition, then advise somebody to stay at home for 7 days? What does that do to their income, their livelihoods? Like, how do we support communities in enabling that? I think home management is entirely appropriate for anyone who does not require oxygen support. And I think actually, frankly, it's probably safest knowing about nosocomial infections and everything else that you can get in hospitals. It is exactly what we're doing here in the UK, which is anyone who does not require oxygen can stay at home, but we have to make sure that there is the facility by which they can be followed up, and that if symptoms get worse, they can be re-seen. How we manage that is incredibly difficult. And I would love to hear from anybody who has found a solution for that at the moment. I mean, we are looking even at how do you assess shortness of breath over the telephone? So there are some nice scales drawn up by GPs in the UK about kind of, you know, can you do your activities of daily living? Can you complete a sentence? How does that translate to my colleagues in Eastern DRC or in Cox's? You know, so I'm not sure yet, and I think that's part of, and how do any of those questions really relate to what your oxygen saturations are, or is that really what we should emphasize? Should we actually just put someone out there going door to door for people with follow-up and measuring their sats, and should that be the sole thing we use? I don't have the answers to those questions yet, but that is what we're going to have to look at.
Sorry, Rachel, did you want to say anything about the?
No, I think, I mean, again, it's again reassuring to know that we're having the similar questions and the similar challenges, and it's, you know, is it the right thing to do to upskill or skill community health workers to have that interface or that sort of connection with people in the household? That level of supervision that would be required outside of COVID is already heavy. So, you know, add COVID to their scope of work, and then you add in a sort of additional supportive supervision. We also have, which is interesting, a conversation, again, it's specific to Cox's Bazar, but it's also around the perception of the resources being, where are the resources going? So obviously the big facilities are being built, which will be, the perception will be that there's a lot of staff. How do we ensure, or how do we have that sort of equity at community level, so there are also people at the household who don't have an option because there are no beds? Are they able to see a doctor or a medical assistant who is able to prescribe, who's able to diagnose, and therefore give them a better chance rather than only relying on community health workers? So it's a perception issue, which also sort of relates to acceptance in the community, that we've got a hospital over here providing care, but also we've got a package of services, healthcare at the household level. So hopefully that will in turn impact on health outcomes, obviously, which is what we want to do, but also allow the services to continue safely, because obviously there's continuing security considerations as well for people in the community, staying in the community to deliver healthcare services. So, you know, there's lots of dimensions to each level of service packages. So whether that's at a household with a community health worker, continuation of essential services, or the isolation and treatment centres, each one has different dynamics and they're all sort of interfacing. It's very challenging to think through all these different approaches. Yeah, thank you.
Do you find that, Dr. Momin suggested that hydroxychloroquine was being used and useful in the Sudan case. And I'm hesitant to ask this question, but in the US, most of the studies that we've been doing so far and the directives I've been getting from my clinical position are don't touch it, it's more dangerous than it's worth and is gonna give everybody tachycardia. And so I wonder, do you have a package of therapies in Cox's Bazar or with MSF that you're offering, given that almost nothing really seems to be working for this virus? And if you do, what's that based on? And is that changing depending on the, you know, obviously the shortages all over the place, or is that something you're trying to standardize? And what would be included in that?
From MSF's perspective, this is absolutely not the core of what we do. We are not, we are not advocating for anything like hydroxychloroquine, remdesivir, or anything like that. I think that the core of the management has to be supportive and critical care or home-based management, and that in a sense, those are the things we need to get done right. Without proper monitoring, the risks, I think, can outweigh the benefits, and we are not prepared to use them unless in a trial setting, for instance, and that's a different scenario, or where they're very strictly controlled. So for us, I really want to emphasize that the core of our management is not about remdesivir or hydroxychloroquine. It is not about ventilators. It is about supportive management as much as possible.
Thank you. And folks are also asking about how you're circumventing logistic shortages in terms of, I mean, I'm sure there's shortages of PPE, but also of diagnostic equipment and therapeutic supplies. And so are there creative ways that you're managing those things? And maybe I'll start with Dr. Momin for that. Can you hear us?
Yeah. You hear me?
Yep.
Yeah. Just I want to highlight something about the hydroxychloroquine and chloroquine in Sudan. You know, Sudan is one of the countries that malaria is an endemic disease in it, and probably since we were children, maybe more than 20 years back, we used to use chloroquine very much in Sudan for malaria, and we don't see any complications for that. And as I remember, people using chloroquine for malaria in Sudan, they didn't do ECG for monitoring at that time. And even everybody in Sudan, maybe he used chloroquine once in his lifetime in Sudan at that time. Okay, and we didn't see that complications in Sudanese people. This is not a very scientific talk, but from the general observation at that time, they don't do ECG monitoring for patients using chloroquine for malaria. We don't see this is because of drug usage at that time. And now when we started to use it for hydroxychloroquine, as I remember, the first patient we used hydroxychloroquine for him to treat COVID-19. He was in the HDU, and he had high oxygen requirement, his rebreather mask, and at that time we were afraid for this patient to be mechanically ventilated. We started him on hydroxychloroquine, azithromycin, and ceftriaxone, paracetamol. And after 3 days, his saturation was 98% of oxygen. This is something marvelous. And he didn't have any fever at that time after 3 days. And I think after 1 week, he was fulfilling the criteria for cure with 2 consecutive negative PCR, and he was discharged home. This is the first one. We used hydroxychloroquine for him, and since that time we used to use it. We don't see any complications in Sudanese people right now. And as I said, really, you see a marvelous response. Yeah, this is what we see. Yeah.
I wonder if he also had malaria or something. That anyway. So
Sudan is an endemic country.
Yeah, exactly. This is sort of an interesting question, especially in light of my U.S. administration's new movements on the WHO. But where do you see the role of the WHO in the places that you work in terms of management guidance, surveillance? Are you using all of their guidance? And given the impending funding crisis there, how do you see that impacting both the COVID response and also the many, many other things that WHO does, especially in humanitarian and conflict settings? And Rachel, it looks like you maybe want to jump in there.
Sure. I mean, that's a massive question, but I think, wow, okay, I'm just trying to see who's on the line, but there's lots of people on the line. I think each agency will take the WHO guidelines that are already contextualized within that response and adapt them as per agency requirements. I mean, I think that's how we always operate. We did the same during Ebola and during other outbreaks. I think the role of WHO has been challenged in this outbreak, and their mandate versus their authority will always be a challenge for them. So whether or not the Trump administration makes a massive change to how WHO operates, whether there'll be a sort of reflection in a year or two on the role WHO took early on in the outbreak, whether that could have been different sort of course of history, who knows? But I think, well, I mean, it sounds trite, but the world will be a different place. So I think UN agencies and WHO as well will look quite different in 2 years' time.
And Dr. Rao, did you want to?
Do you know, I am a clinician, and this is like a health policy question, and I'm really sorry, Rachel, but I'm going to duck it and just say I think that our colleagues at the WHO have done an incredible job at putting together advice and guidance at really short notice. I know any of us who are kind of reading the various trials and everything else that is coming out, trying to make sense of the data constantly. It's huge, and I think they are doing an amazing job at putting together the stuff that they have done. I think exactly as Rachel says, you know, this is challenging their role, their model, their way of working, their approach, and whatever happens, we have to adapt that guidance for the context in which we work in. And it's quite clear that, in a sense, you know, most of their clinical guidance it includes testing, and that just isn't going to be the case for our settings. And you know, their guidance, their case definition is probably not good enough at the moment for pediatrics, but I think they would acknowledge that. But part of that is also that we ourselves need to contribute our learnings from our experiences and our programs in order for this to be, in order for definitions to be refined. So I think that there's a lot for us to also contribute there. And as always, this will be a matter of tinkering and adjustment to see, you know, which bits we follow of WHO, which bits of national protocols we have to follow. And of course we do. So I see in the chat, someone's asking me about, you know, do we follow national protocols or our own? We will always try and be in line with MOH protocols where we can do so safely. And I think that that's exactly the same with the WHO guidance. So on their role beyond this, I'm going to allow Rachel to have that to say. Sorry, Rach.
And we're almost done here. So I wanted to thank everyone for speaking and mention that some of the guidance that you spoke about on the presentation, I think it'll be available on the website. We encourage everyone to share their perspectives on the COVID-19 humanitarian.com, I think, website. And now let me turn it over to Paul Spiegel to give a few closing remarks.
Thank you, everyone. That was really an extraordinary discussion. It also really highlights how much we don't know and how complex it's going to be, particularly in countries where there is insufficient testing, which is probably nearly all countries at this point, sadly. I really want to just say thank you to all the colleagues, because there was quite a diversity of opinions and views here. It would be wonderful to share the various protocols of what people are doing, because we have seen a lot of confusion, not confusion in the field, but organizations and ministries of health making decisions about this is how they are going to be addressing this. And it's everything from what are they going to do with when we have comorbidities occurring, and where clearly if you have a positive rapid diagnostic test for malaria, that doesn't rule out COVID. And the syndromic way of addressing this, as you mentioned, is so, it's quite diffuse and it's quite generic. And so it's very, very hard to have a syndromic diagnosis without testing to know if this is COVID or something else. There's a lot more to discuss, and so and there are many, many more questions. Ready does have a chat room. Feel free to use that, but we can perhaps think about some further ways to discuss, particularly the protocols that NGOs and MOHs are using in the field, because this will be evolving. So it'd be wonderful to share that. Next week, we're going to switch gears, and we're excited to look at water and sanitation and hygiene promotion. Les Roberts from Columbia University will be moderating that session, and Sean White from London School, who also is involved in the Hygiene Hub, will be the expert on that, discussing just like Bhargavi just did, to discuss what some of the broad protocols and guidelines are, and then we will be having two discussants from the field as well. So thank you everyone as always for your participation, and we look forward to seeing you next week. Bye everyone.